Third time's
There
a
we
charm. Can everybody see that perfectly? Wonderful. So again, today we have our friend Ryan Kelly coming in to talk about improving access for people with substance use disorders. And everybody knows who we are, probably.
All right. So next week, Kurt will be talking about the ever exciting topic of substance use disorder and suicide. We have a week in there we're still working on. And then moving forward, March 1st, this judge out of Tennessee, who's actually our moderator in Atlanta this year, we met him on our little meet and greet for Atlanta and got him signed up immediately. So a lot of different varieties of talks coming up.
Yeah. Lots of fun. Remember, there's CME. It is free. And just remember, please turn on your videos if you could. It makes it much more fun for Ryan to give a talk if he sees people. Although he
did that today. So.
Yeah. And he's
spoiled.
Yeah. So yeah, please feel free to turn on that video so he has somebody to talk to.
And if there's more than one person in your room, please chat that in as well.
All right. Remember, if you have any questions, please just give us a ring. All of our numbers are there. Most of you probably already have them. Yeah, you can also, Erin's phone number is there as well, our nurse on the program.
The online site, if you want to get old recordings, you want to sign up for different echoes, you can go check that out there.
This week on the Addiction Connection, it was
Kratom
2.0.
Yes, so
yeah,
check that out. Next week will be kind of the harm reduction / weird nuances of Kratom. We talked about that in Echo a few weeks ago, so kind of a refresher of that. All right. So with that, everybody, we would love to introduce you to our good friend, Ryan Kelly. He is pretty much on the level of a Charlie Resnikoff.
Well, he's right there. He's right there.
We'll start calling you the Ryan Kelly now, just like Charlie. Anyway, Ryan, are you sharing your own slides?
I am, once you allow me to.
Oh, I just wanted to make sure I knew to take them down.
Yeah.
So yeah, Ryan, family doc, now addiction doc too, works at the Cook Clinic in the cities. He does all this volunteer addiction, everything, everywhere. Ryan, we'll just let you kind of explain what you do because we don't even actually know.
Yeah, I mean, he makes the rest of us look kind of lame. He's the guy that if you want to get something done, you get Ryan involved because he just gets it done. So
I like to think I'm good at poking the bear, but a couple things. Thank you for the intro. It is an honor to be compared to Charlie, but he's a mentor of mine. Let's see, I'm internal medicine pediatrics, mostly semantics, not family medicine, but it just means I am allergic to catching babies. Let's see, I do wear a couple different hats. I practice primary care at the Community University Healthcare Center in Minneapolis, which is a low-income FQHC federally qualified healthcare center. So work a lot with people without a lot of resources. I'm a hospital medicine doc at the University of Minnesota Medical Center. And then I've been an addiction doc for the past couple of years as well, with goals of just trying to improve healthcare access for folks who use drugs. I'm going to be talking about a subject that I've become more knowledgeable and more passionate about over time, which has to do with the consequences of the war on drugs. I just popped in the slides, and I'll do it again here.
The Jay-Z thing?
Yes, there's a Jay-Z video that we don't have the time to watch today, but I recommend pasting it and watching it later. It's a really good video that talks about the negative impacts of the war on drugs. And so, I think the more people talking about and knowledgeable about this and just, able to discuss a potential improvement, the better. So I will jump right in here. So the social determinants of health play, a key role in driving health inequities. We all know that. The war on drugs exacerbates a lot of factors that negatively impact health and well-being. Disproportionately, as I'll show you, impacts low-income communities and people of color, subjects millions of people to criminalization, incarceration, criminal records, and that disrupts and eliminates access to resources, including, access to employment, housing, public benefits, family regulation, healthcare, et cetera, and is well documented to not decrease drug use or the complication of drug use. And I think we as medical providers can really play a huge role in promoting individual and community health by reducing the impact of criminalization and also, as I'll talk about, becoming engaged in policy reform. So everyone is familiar with the fact that overdoses are skyrocketing. And so this is just for Minnesota, overdose deaths until 2020 in Minnesota. And when we pivot and look at, because I'm going to discuss in a moment who's more negatively impacted by criminalization of drug use. First, when we look at who uses drugs, this is national data. For the most part, no matter what someone's racial or ethnic identification is, drug use is pretty similar. This green bar and the gray bar are people who identify as Indigenous Americans or people who identify as being two or more races. Is slightly higher than the other bars, but it's only 1.3 times and 1.7 times compared to white Americans. So point being, there's not a lot of difference in who uses drugs. But when we look at racial disparities in overdoses, people of color, especially if you identify as Black or Indigenous, American Indian, or Native American, it's much higher. When you look at who see, what the racial disparities are in the rates of people of color in Minnesota who are arrested for drug possession, it's also very obvious. Indigenous Minnesotans were 5.4 times as likely to be arrested. Black Minnesotans 3.9 times as likely to be arrested compared to white Minnesotans. And when we look at who's convicted, those same disparities exist. Again, when it comes to sentences, when it comes to jail time, prison time, much more likely to face a sequela of this if you're of color. Estimates from 2018 suggest, 1 in 5 Minnesotans have criminal records. So I'm not going to read through all these distinctions, but conviction records can last as long as 15 years. Arrest records, if you're arrested but not prosecuted, if you're released, whatever, that can still be on your record for up to 7 years. And so all of these serve as barriers to a variety of social determinants, like I mentioned, including housing, employment, and even food via SNAP. I will say one existing thought in Minnesota at the exact moment. Hennepin County, this is the only place I have numbers, but I know with Heather and Kurt's work as well, more and more people are getting access to substance use disorder treatment in jail. And so, Hennepin County treats about 4,500 people with Suboxone in jail per year. Now, what percent of those people only had access by going to jail, right? Do we want to emphasize the few people who are able to say, phew, thank goodness I got arrested, it saved my life, right? What's the number needed to arrest to actually get to that point versus the percentage of people that are negatively impacted? Versus the flip side is access is so limiting, people need to go to jail to get services. All right, I think those are two sides of the same coin. It depends how you want to look at improvements. So I'm going to transition to talk about a possible solution. I think the first idea is the current process of arresting people, locking them up, it's decreasing drug use, is it decreasing complications of drug use like other crime, overdoses, or infections secondary to the way people use their drugs. Or is it negatively impacting lives? And again, as I said, pretty clear, it's negatively impacting lives. One option that is getting more traction across the United States, but here in Minnesota as well, is talking about decriminalization of possession. This is different than legalization. Decriminalization, as it says here, is the removal of criminal penalties, but not civil penalties for low-level drug offenses. Legalization is removing both criminal and civil and allows the government to regulate drug production, supply, and sales. So we're going to be talking about decriminalization of illicit drugs moving forward. This is something that's been around in different parts of the world over time. Portugal, they have had a decriminalization program since 2001, have had, massive improvements. Their overdoses are much less. Their major decrease in HIV and hepatitis C, et cetera, and they have not had an increase in morbidity and mortality. Oregon in 2020, voters approved, it's called Measure 110, which decriminalizes possession of drugs and also increases funding to addiction services. To date, they have not had an increase in use or overdoses compared to surrounding states. They've had massive reductions in arrests and convictions. And this is without most of the money that's supposed to be going to increase access happening yet. This just shows the orange line that, the blue line is arrest for possession, and there's been a massive decrease in that. Some other examples, Baltimore in 2020 is no longer prosecuting drug or paraphernalia, and they've had a significant decline in arrests. They estimated that they averted 78%, 443 arrests, and that positively impacted people of color. A lot of people wonder if decriminalizing is going to lead to worse public safety because folks aren't in jail, they're out causing problems. And there isn't any data to suggest that. Baltimore is a good example. Looking at 911 calls, looking at arrests, there's not an increase in arrests for serious crimes or 911 calls. It also kind of suggesting that public safety is not negatively impacted. So as I wind down, there's lots of benefits, potential benefits of decriminalization. And so I think what I wanted to pause and talk about is what would decriminalization look like in Minnesota? Who would be impacted and how? Obviously, the people that get arrested, obviously justice system folks, from prosecutors to police, sheriff's office, jails, to treatment folks. What kind of access do we have if people aren't being funneled into jails? So I'm going to pause for a minute and see what thoughts, questions, concerns people have and try and answer some of them. Otherwise, take notes. But I guess before I do, there is more and more traction in Minnesota looking at this. The Minnesota Medical Association has recently voted to support decriminalization for simple possession. Actually, as of an hour ago, they voted to support other harm reduction policies, including policies that are supportive of certain service programs, policies that get rid of paraphernalia laws. People can get in trouble for carrying syringes, and also support overdose prevention centers. And so I will pause and see what questions people have. So I'm going to stop sharing for now. If we want to talk more about harm reduction, I could, but I'll stop for now.
Okay, so I would love to be able to call on two of you for sure. I know are sitting in jails right now, to maybe give an overview on what your jail looks like as far as who's in your jail in terms of primary drug charges, multiple other charges, and what have your jails look like recently. And you two know who you are, at least one of you outed yourself in the chat. Just curious because, Ryan, you just asked us about that. These are nurses or direct people working in patient care in jail. So do you guys mind?
So I can share. So for the population that I have here in our current county jail, I would say at least half of the people that are here on drug-related charges are Native American descent. A lot of them aren't even from this county right now. We're housing for a different county quite a bit. But people that are from our home county here, I would say are Caucasian or white for the most part.
Are they on primary drug charges, Audrey? Are there other?
A lot of them are probation violation charges. And I think that goes back to what Ryan just said. They're not committing serious crimes anymore, but they're still getting in trouble because their probation states that they can't be using drugs. And if they get caught with, XYZ paraphernalia, when they come in to talk to their probation agent or what have you, that lands them back here in jail. And, then it's just the revolving door of problems for that person.
Thanks, Audrey.
Yep.
Zachary, do you want to comment?
No, I have too much to comment. Audrey, what jail are you in?
She's in Morrison.
I'm in Morrison County.
So I work in Stearns today. I'm in Wright and covered Todd counties. And you can, I'll put the link. Stearns is a good snapshot of what we see kind of statewide because we have a variable population reflective of inner city and rural areas. So we've almost seen part of the system on its own, not quite decriminalized, but empty out jails real quick if it's simple possession, because there isn't room for people in anywhere. but then these people get lost in the system because, it's probation requirements. They miss another court date. Life falls apart because they got possession, right? And it doesn't work, and it's impossible for the system to keep up with that. So I'm glad the Medical Association is doing that, because it would be a win for everyone, reduces some stigma and breaks down barriers to getting the help they need. I hope that kind of answers your question. Other than that, just the population of severely mentally ill here. I mean, jail captains will tell you it's more of a psych ward than anything else, but then that cross addiction is quite profound.
Awesome. Thank you. What do other people kind of think about that? This was always one of those very initially polarizing topics. Like you say decrim and people think, again, legalization. I know Ryan kind of said what it's shown in other places. What do you all think that would show, here in Minnesota or in your communities? Because Minnesota is variable depending on where you live in the state too. And that kind of thought. Anyone else have any kind of thoughts or comments on that?
Oh, go ahead. Yeah.
No, go ahead, please.
Oh, I was just going to make a comment to generate more conversation. So go ahead.
Well, I think it's interesting because I had a conversation with some people just literally a week ago from the Morrison County area. And somebody said, we just need to make the laws stricter so that people, go to jail longer. And I just thought, that it's just so different from the way we think, right? I mean, because we see this happen to our patients who are good people who have a bad problem. And it's like, it's really about education for, I think, not just the addiction groups or the medical groups, but really for all of our, all the people in the state. And it's tough sledding to get that done.
Yeah. This is Jem Watson, med safety pharmacist over at Centricare. I've been thinking about this too, and looking at, we're not serving our population the correct way. We're punishing people who have addiction issues when we're looking at people that are selling. And I know sometimes there's that crossover between the two, but couldn't we take that tax dollar money that we're putting into the system where they're not getting any help into systems where they are getting help? And so it really bothers me that we talk about this idea of punishing more, where, then I also look at some of the pharmaceutical companies that have also helped create some of this issue of addiction. And looking at it to fentanyl right now, there was just an article out about fentanyl and how in the world are you even getting that? But yeah, it's out there. And so how do we look at this to help people? And, not only just that, is also to look at it from that of giving them career, giving them technical services that they could use to go out to get a job, doing all of those other kinds of things, and not just looking at it as, we need to look at it as a disease state and not necessarily as a punishable crime. Sorry, that was a lot on the high horse.
But no, you really hit the nail on the head. I think, Decrim has been shown repeatedly to save hundreds of millions of dollars, right? If you can, compared to what's the cost for someone to, have access to Suboxone, or even the cost of residential come-to treatment is still way less than going to jail. And, when we talk about the generational trauma that and the repetitive cycle of jail. So no, your comments are, yeah.
Mm-hmm. Well, and then and I'm going to just say this because it pisses me off that the insurance companies don't cover Suboxone. Really? You have to get a prior authorization? What do we need to do? Scoop you off the street somewhere, take you into the ER, and then throw you into jail? Is that considered a prior authorization type of thing? Come on, guys, get with the program.
So Jennifer, when we started doing this in 2016, we would actually call the insurance companies because they said the whole thing. And we would say, ask for the supervisor until we got to the top person and say, what's your name? Because we want to know who to call in 3 days when this person dies, waiting for your prior auth. Oh, here you go. Here's your script. It's authorized.
I've got a brother because of that has no longer with us, that's sitting up at Camp Ripley because of a drug overdose, and that passed away. So yeah, it affects a lot of different people.
Right.
I've been thinking a lot about, I've been taking this curriculum from SAMHSA, and the first module is about, explaining, of course, addiction. And you guys have done this hundreds of times. But I'm wondering if we're kind of on two ends of the dichotomy, if you will, in that we have to acknowledge that it's a chronic condition, right? But maybe we're not doing a good enough job to say, but it also, and not but, and it oftentimes also has behavioral implications, because it seems like, the pushback, that sometimes we get is about, you weren't living in that situation and it impacted every single person in our family and things like that. So I don't know. I've just been thinking about that a bit.
Sure. Joe, do you have Joe had his hand raised for a while, so.
Yeah, no, I just want to, I appreciate this conversation. I think this gets complicated because of the nature of politics as it stands here today. And I think it makes a big difference. I think because people bring their moral and preconceived ideas about addiction that we've been inherited within this generation that have gone back a long ways. But when you do think about it, doesn't it make more sense that we should be taking resources that are currently going into jails, and especially in light of what we saw from the Department of Health regarding homelessness and the amount of mortality related to our homeless population and related to substances, that we should be housing people. There is no question that the data around putting resources into stable housing saves lives, reduces morbidity, not just for people with substance use disorder, but with all chronic diseases that people have. And it saves money within the healthcare system in regard to hospitalizations, as well as emergency room visits. So it's a matter of our public policy that leads us into this situation. And the more people can get involved with their representatives to try to push things through, the better things can be. And it's exciting to hear what has happened at the state legislature today. There's a great opportunity in Minnesota right now, because this current legislation would probably be more open to this discussion than previous legislation. So it's really an opportunity for everybody to make their voice known, their self known to their legislatures regarding this.
Yeah, and I want to comment on the Portugal thing, because there was a comment in there about the funding and where the money went, and this whole concept of put the money where the treatment and all of that. And the Portugal model I love. I don't love Oregon. We've had a lot of conversations about this in our harm reduction Decrim group that we do, and the way that Oregon did it was a little backwards, in my opinion. Portugal has these kind of teams that kind of, when a person gets arrested, they have almost like this team that kind of analyzes what's going on with that patient, offers them these different services, which looks similar to drug court, but not drug court. It's more almost that wraparound team that works with the patient. But yes, the funding did go into that. I think some of the issue right now, to answer the question of, yes, it's saving all this money, but you have to try to convince somebody that you have to invest the money up front to get whether it's treatment in the jail. Let's get everybody started on Suboxone when they enter the jail, like Hennepin's been able to do, and better than anybody else at this point. And then look down the road, we'll be able to show, yes, this was cost savings. And so it's kind of trying to convince a bunch of, like Dr. Bianco just said, a bunch of politicians that, hey, you're going to invest this money and you're going to have a hope and a prayer, and a bunch of people who everybody thinks are just dirty addicts in their mind. And so it's trying to take a lot of shifts and a lot of faith. It's where I see a big gap.
Ryan, I think often when we talk about decriminalization, and I think when you kind of pulled that group together initially, to me, it just seemed like this would never go anywhere. I'm going to be honest right now. And I base that on the fact that the work that we've been doing for years, trying to get even buprenorphine in a jail, because it's okay to let somebody sit in a jail and suffer if they have an addiction. That's somehow okay. And we can't get that little thing changed for people. And so this decrim thing to me seemed like such a jump what in comparison to the little step we were trying to take just to have people treated humanely. So it, I mean, this is tough.
Great. Yeah, it's interesting you say that because that's kind of how when I started, a year ago, that's kind of where I was. And in fact, working with some of the harm reduction boots on the ground folks at the moment, they're kind of, well, Ryan, Minnesota's not ready for decrim. There's what's the temperature? And that's where I think having, larger medical groups, the ACP, MAFP, the Minnesota Medical Association, have them support, that's lobby power. All right. And again, going to my initial comments when we started this talk, medical providers, when we are involved in policy, boy, do we carry weight and make noise. And so do we try and move forward and make a state change in the next 2 years? Do we go slower and make it perfect? Those are all kind of the background conversations happening right now.
Okay, I'll be a devil's advocate, or just to raise one issue I'd love to hear you respond to, if that's okay. This has been an incredible discussion. So I definitely believe from the tobacco literature that what governs a young person starting a drug is social acceptability, perceived by in the eyes of the young person. Is this drug socially acceptable? Perceived safety in the eyes of the young person, and availability of the drug. If a drug is available, acceptable, and perceived to be safe, why wouldn't they try it? And that's established for tobacco, and all of the things that are being done to lower tobacco rates, getting people out of movie theaters and commercials smoking cigarettes, like the actors don't smoke cigarettes anymore as much, and diminishing access and making tobacco seem unacceptable socially by you got to stand outside on the sidewalk under the hot lamp, et cetera. All these regulations are affecting those and actually lowering tobacco use. So my question is there tension between caring for people with a current addiction and preventing young people from experimenting with drugs? Is there a tension in decriminalization that it could change the perceived social acceptability of drug use? So that's my question.
Well, that's such an awesome question. I really want other people to chime in as well. I think to when I was in high school, exactly like you said, there was cigarettes, there's weed, there's no booze, right? Someone under 21, that's really difficult. And there was a couple of, but kind of that hard drug acceptance, has changed, right? We think about what happens to communities when you don't screen because you make assumptions that because of someone's religious or cultural beliefs, they don't do drugs, right? And so I think that's a super important question. But I also flip it to when was the last, who can remember this is your brain on drugs commercials? Who can remember that?
Yeah.
When was the last time anyone saw a commercial about drugs?
Ryan, I'm going to say this one little thing just because it's kind of fun. My son, when I came home from school one time, had seen that commercial about this is your drugs and this is your brain and this is your brain on drugs. And when I came home, he was holding a plastic brain and he said, Dad, this is your brain. And then he set it down on the rug and he said, this is your brain on rugs.
Okay, I'm going to make.
Sorry, I had to tell that.
Yeah, I'm going to make two comments. One to that comment, the whole brain on drugs thing. I actually talked about this with a patient of mine once. She's definitely been in recovery a long time from literally everything. She's worked her way back and has a pretty high, important managerial type position in a company. Had lost one son to an opioid overdose a couple of years ago, and the other one is also in recovery. We talked about that commercial probably 4 years ago, and she made the comment, oh my God, do you remember that commercial about the eggs? She said, you know what that did to all of us addicts who were using? It made us really hungry for eggs. It didn't change anything else that we were doing or thinking. It's like, okay.
I was actually just typing in the comments and I'll just stop typing. That example that popped in my head maybe wasn't the greatest. But the point being, we don't talk about education. There isn't a lot of education. And so there's a lot of room for that in, high schools, et cetera, family education, et cetera. And a big part of that is, I think, my comment a moment ago about if we're not screening, if we're not talking about it because we make assumptions. So again, my thoughts on Charlie's question is there definitely could be tension there. I think it needs to be addressed. Education is one, and I don't have the answer, but a really important question you asked, Charlie.
So the comment though with the drug access, actually, Charlie, I love that you asked that question. Yesterday, I saw a new patient. He's 23 now, cannabis use disorder, alcohol use disorder. He moved to Minnesota at the age of like 20. I'm looking at our student. She was with me, 18 to 20, maybe it's even 18. He used, I can't even explain to you how many bowls of pot he smoked a day when he lived in Colorado as a 14 to 18-year-old. Like it was acceptable there. I mean, because it has access and it's just there. Moved to Minnesota, he still uses it, but much, not even every day of the week and much less. And I said, well, what changed? She's like, it's just harder to get. Just, talk about that. And that's more that legalization thing that I see in terms of, like you're saying, socially acceptable in terms of the criminalization of it. I think if you're going to decriminalize it, therefore make it appear to be socially acceptable, then it has to equally be shown that treatment and going to treatment and embracing help is actually also just as cool as not going to jail. I think there's going to have to be that same equal push that has the same weight of going to jail. Because I agree, huge deterrent is getting arrested. Talked about that with the patient this morning too, is that's a huge deterrent to lapses if you really don't want to go to prison. Of course, only the Charlie Resnick would come up with a question like that to throw out harm reduction coalition out the window, Ryan.
Yeah, but nobody.
No, I'll just say, I don't think that they're incompatible. I think you can do both, but you just need to be aware of both. I mean, you can humanely treat a person with addiction without encouraging future addictions, but I do think it takes awareness. And I don't think you have to thread the needle.
Yeah, this is Jen again. I've got my husband actually is a middle school teacher. And I think too, as we talk about this, is looking at those downstream effects that it has on those families and on those kids. There's many times when he has conferences where parents don't show up because they're both in jail. And what does that do to that child? Even though that child, he has children that come in that they come into the conferences on their own because their parents are in jail and don't like that behavior. Is what are those percentages of those kids that will go and have that behavior as they grow older, because that's what they've seen. And so then how do we help translate that down to those children to make them feel valuable and to make them not go down those roads?
Charlie, one of the things that you talked about is that it's perceived as being safe, right? And I think that one of the interesting things is that who do people in the age groups that we worry about get their information from, right? And so they're getting it from people around them who don't have that information. But then again, you look at some of the programs that have for drugs that have gone into schools like DARE and other things, which have been shown not to be all that effective. And so I guess my question back to you would be, how do we get that this isn't safe message to people that are at an at-risk situation?
And I think, go ahead, Julie.
Maybe Ryan has it. I don't know.
I was just saying, to comment on what Jennifer said, because it kind of loops it in there, is getting it to the people who are even the more high-risk youth, like getting it into the schools. But then, when we went into holding court with Monica, like the kids that needed to hear were the ones not there because parents or wherever. And it, everybody needs to hear it, but then there are certain ways that you need to try to address those who have that historical, who have those ACE scores from their parents that you don't want to slip through the cracks either.
I think really looking globally, is kind of the two issues are addressing hopelessness and addressing access to the social drivers of health, right? Kids are going to experiment with stuff, right? If they are more educated, then hopefully when they experiment, they're smart about it, right? There are people who experiment and have all the resources in the world and then become, develop major substance use disorders. But I think if we look at Decrim as a way of preventing negative consequences of the war on drugs, and then making, having an educational front, and then finally in access to treatment that isn't just kind of one way is the highway. Looking at, Christine asked a great question. Do we sentence addicts and dealers to inpatient treatment? My personal belief is if someone wants to use a drug, educate them on how to use it as safe as possible. And then over time, if they want assistance cutting down on their drug use or avoiding drug use, find out what their goal is and what their resources is and come up with an individualized plan, right? Yeah. Someone may, want to focus on their cultural supports. Someone else may want to go to, an abstinence only faith-based treatment center. But I think that those are kind of, the approaches we have to look at.
I think as we look at kids, and I often remember one time my son asked me, my oldest son was one of these kids that asked me to do something. And I would say, well, I don't think you should do it because of this and this and this. And he would say, yeah, but what are the things that could go right that would make this a good experience? And I'd be like, what? And I think that when I see teenagers, and we're seeing a lot of teenagers now, not just marijuana, but also, fentanyl. And I don't just go to the bad things this could do for you. I say, listen, you're probably getting some benefit from this. And this is the things that you might be experiencing. And I get that because I took away from my son the fact that I can't just say the negative stuff, because then he's, I've got to admit that, yes, there are marijuana. Maybe it makes you relax. Maybe it helps you sleep. But here's the things that we need to be concerned about going down the road. And I think that's probably more effective than just saying, wow, you're going to fry your brain. There it is in the pan, that egg.
I do like that.
Heather and Kurt.
Yeah.
This is Chris Manson. And I just wanted to throw out something and see if anybody has any responses. When I was doing my fellowship, Sheila Becker expressed an interest in trying to work with grade schools, even preschools, high schools, in prevention education. And as a pediatrician, prevention is supposed to be our middle name. So I was kind of interested in this. And a few years ago, I looked into, why reinvent the wheel? I was actually thinking about going into the Ashland Public Schools and giving some talks about addiction medicine related things. And I looked into public school, private school, early education for substance use. And I think, if I remember right, I think it was NIDA, and they had a whole bunch of modules that somebody had developed that you could just take them and bring them with you to the school or the preschool or the whatever it was, so that you didn't have to reinvent all that yourself. And if you wanted to use it as is, you could, or if you wanted to alter it to suit your own needs, that's fine too. But I think it's going to, in terms of prevention in public schools, I think the tobacco education has been a real lesson, and I think it's been very effective. I have patients all the time who tell me, I just have to quit smoking because my 7-year-old son is on me all the time. He does not want me to die. But I never have a patient that says, I just got to quit this meth because my 7-year-old son is really on me about how dangerous it is. I've never heard that. So I think people like us, and I think we have to do it independently and not get paid for it, because I doubt very much we'll have organizational support to go into the schools and make a commitment and say, I'm here, I'm available. I could give once a month or twice a month talk about substance use matters and gear it up or down depending upon how old the child is. And I really think that prevention is one area that's been sadly overlooked, probably in large part because it's not reimbursed. Anyway, just my thoughts, and wondering if anybody is familiar with those NIDA modules.
I have not seen the NIDA modules. What I have seen and done is when we first started doing this in Little Falls, we actually was it DECA, the whatever school thing did this as their project. And we had opioid awareness week. We ended with one of our patients coming in and doing her whole story and the question and answer. And then we change the outcome in later. That is, I feel very strong. Like Allison had mentioned her brother, who we've seen on Echo before too, almost those self stories and telling those stories. And that's why Change the Outcome was effective, is because Colleen, who developed it, used people who were closer in age to the school age children, like she's in her videos. And when they come in and they have a panel in front of the youth, they are more relatable than any of us who are older. Like they remember things because they weren't there that long ago. Kids listen to kids, it's the whole peer pressure thing, both directions. So
can I throw another bomb into the conversation?
No.
Just one more time. Oh,
Dr. Rouse is in the room with me, joining me. But so I think all the data you showed, Dr. Kelly, about the racial disparities in the war on crime is like very, very compelling. However, and again, this is a bit of a devil's advocate argument. I think that the forces in America that lead to racial disparities in criminal justice are bigger than the war on drugs. And I think if you reform drug laws, you will still have racial disparities in criminal justice. And it will happen under a different name. It'll be a different law. Instead of public consumption, it might be loitering or something else. But I think we're not going to fix racial disparities in criminal justice with drug reform alone. What will happen is people will be incarcerated for other reasons, but they will still be incarcerated. And that was one of the lessons from Colorado's cannabis legalization, is they legalized cannabis, but no public consumption of cannabis, which immediately meant that people who didn't have a house or lived in Section 8 housing had nowhere safe to use cannabis. They used cannabis in public, and cannabis arrests of African Americans in Colorado did not decrease with legalization. So because there's all these systemic issues making it complex to actually fix racial disparities. So anyways, I think it's a really compelling and interesting thing, but boy, I wouldn't promise improvements in racial disparities. I wouldn't promise it, because I think it's a very, very deeply rooted issue in America that's going to be complex to fix with many, many inputs. Anyways, that's the grenade I'm throwing into the conversation. So I don't know if,
Well, Charlie, I don't think that's a grenade at all. I think it's because the point is, generational trauma, lack of social drivers of health. That's the only, plus racism and stigma and bias, right? And so, decriminalization is one small part. And so, but I think, I agree completely with what you're saying. There's a lot more work that needs to be done besides this.
But I think what everybody's saying, which is very true, is like decriminalize the disease of addiction stands on its own. Like, it doesn't need to make money. It doesn't need to fix other problems in society. It is like self-evidently the right thing to do. It's like a human right. Someone has a disease and they're being sent to jail for their disease. And it's like, we don't need to justify it any more than that. It's just like, we're sending someone to jail for the effects of their disease. And so in some ways it should stand on its own without any additional, it doesn't need to be profitable to be the right thing. If you know what I mean.
Well, you tell that to the politicians and business people, Charlie. Come on now, you know that. I wonder though, and I totally agree with all of that, with the whole, it's not going to change racial disparities in any way, shape, or form in all likelihood. However, I wonder if decriminalizing will then, if it is also matched with reform of treatment. I agree with you, Zachary, that the whole chemical dependency treatment world, there's a lot of areas. I mean, I think overall inherently it's getting better. I think people are coming around to harm reduction. There's different ways to skin the cat and all of that. But also, if that is matched with the mental health is matched with the decrim, and you have that whole network built up, then potentially where all the disparities lie, maybe there is more access then to care and more willingness to care, or more outreach to different communities that previously have not had that same level of outreach to them for people to get help. So it will definitely not be, direct causation here, but, the fallout of all of it. But I think it can't just be one thing. You can't just decriminalize and expect things to get better without having the equally matched mental health, substance use treatment, access, I know, it's funny.
I don't know.
I'm funny. It's
I don't know
okay.
about you, Ryan, but now that Charlie's kind of launched that first grenade, it's like I really do want to see what happens after decrim, because that data is there, right? I mean, we're still going to be collecting that data. I'm starting to think he might be right. It scares me to think so. But yeah, I think that it's interesting because I think we may find other ways that the disparities play into this. Mm-hmm. So.
But if it's one step, because we know what the war on drugs did data-wise, if we're looking at different populations and the disparities. So if you take out this one step, yes, it could just get a new title or a new topic or a new charge or a new whatever, but that just took out one of the bricks in the wall. And now we have to then address the next brick in the wall, which was another grenade that was thrown into the different populations that were stigmatized against. You know, just because this one won't be promised to fix it, Charlie, doesn't mean it shouldn't be done.
He didn't say that.
What I think, I definitely think it should be done. What I think will happen is I think it will affect overdose rates. Because I think it's really clear that when someone's incarcerated, they lose tolerance, they get released, they're at risk. I think that cycle of incarceration and release fuels the death rate. So I 100% believe that reducing incarceration will reduce death, along with treatment. But whether it will reduce, racial disparities, I just, it's such a huge issue. I don't know, but I believe, like from the Portugal experience, that I think it will reduce death. I think that's a good reason to do it. I don't know. That's my opinion.
Well, I also look at this as we've got to do this kind of as a PDSA. You know, we always have to have that understanding. I think we have this society that if you do something initially and it doesn't work, what do? You don't fix it, you just drop it. But I think that this is such a deeply entrenched psychosocial, however issue you want to look at this, is that we have to continue to learn from it. And what can we learn as we go along? So I'm hoping that that's what we do. We don't decriminalize and say, well, this isn't working because we can't do it this way. We have to continue to learn from it and grow from that.
You know, Ryan, correct me if I'm wrong, but isn't it, and it's been a while since I've read the Portugal stuff. I don't read this stuff every night like you do, you know, before bed. But isn't part of this that the decriminalizations, then these patients are then offered treatment and they're not forced to do treatment, correct?
Exactly. And, you know, there's, Vancouver, is that British Columbia?
Yeah.
Yeah. So British Columbia, they are just passing decrim rules in which, if the police are involved with someone and there happens to be substance use involved, they give them a card with easy access. But there's other models where there's, imagine if, depending on the size of your town, there's a drop-off center where people can get dropped off and they can either get a ride home from there, or they can get access to treatment, or at least meet up with a peer support specialist, right? So there's all sorts of different models.
Okay.
It's very interesting. Earlier, you talked about in our community and how people said they need to have tougher laws. I got a text right before we came here from law enforcement in that same community saying, I am so sick of arresting these people, Heather. Where can I send them to get help? This is getting old. Flat out text from one of the drug cops. So, I mean, it's two ways. It's also depending on who in the community you're talking to, and what they're seeing and what they're facing and where their perspective lies.
But, that's one of the missing, in our coalition of people that are kind of coming together to look at this and talk about state bills, et cetera. We've got, large city prosecutors who are very much on board, trying to wait for input from, more boots on the ground, sheriff and police is what's missing. And I think trying to figure out how to bring decrim to them to get their input and to get support. All right. And I think that's the issue. You join the police force because you want to improve lives, and you are, you just see someone in the perpetual cycle. How do you help get them out of it?
Yeah. What have you done? Any other comments? Any other thoughts?
Allison, I know you had your hand raised and then we kind of went off on a different tangent. I don't know if you're still on and you want to circle back. I think we were talking about schools or something, but.
Yeah, I'm still here. We've been, So I'm on our county's committee for dealing with the opioid settlement dollars, and like a huge thing that we've been talking about is like all this upstream prevention. And I feel like those of us who participate in caring for people who struggle with substance use disorder, like, get that upstream prevention is so beneficial, which is why we opted to go into the school and provide some of that, hopefully some of that preventative education up front. But it's amazing, like, how many people in those decision-making positions, like, don't even want to have those conversations. Like, people with our county social services and people in the school districts, like, don't even want to consider bringing some of this education, like, to kids. And I don't really understand, like, it's kind of like, if you offer condoms, like, you're going to convince more kids to have sex. Like, for some reason, that's kind of what it feels like. And if we talk to kids about fentanyl and overdose and Narcan, like, more of them are going to go out and use. It's just been a hard conversation on our end to try to convince people that this is valuable.
Yeah, and it's the parents calling.
It's the parents calling. We had this in our school earlier this year about a bullying talk, and it became a nightmare in my kid's school. And so you're right, Allison. It's interesting how there's this whole belief of parents that if we don't teach this, then it'll go away. It's like, you are literally living in a totally different era here if you don't think your kids are going to be exposed to this. And I personally, like, I'm sorry, my elementary school kids know what fentanyl and Narcan is. They live in my house, but it can't be this overly big, scary thing where they're like, have no idea what they're talking about. It has to be a normalized conversation. So then they're comfortable in the event that they have exposure, they know what to say and do to it, or they can help other people know what to say and do around it. Because the threats just clearly don't work. And it's hard.
Yeah. What you can talk about in a school is, it's what the response the parents have that often dictates what's said. So, yeah. Well, we're just about out of time. Any parting thoughts, Ryan? You've stimulated quite the conversation, it appears.
I just want to, when I was kind of working on this talk, I've given very similar talks like this in the past, and this is a very rich conversation. This is exactly what we need to have. I think outside the box, thinking of the challenges, making sure Charlie's involved to make sure to throw cannonballs. I really appreciate everyone's time. Thank you.
Good thing we reviewed all 6 of those slides we ended up getting through, right?
So thanks everybody for coming. Next week, I'll be giving the talk on suicide and substance use disorder, kind of a touchy subject, but one that we all need to kind of hear. It's actually been a really interesting talk to pull together. So I hope we see you there.